Imagine you are just washing your face one morning, right? And right there, just in front of your earlobe, you feel something.
You are,
Exactly, a lump. It is small, maybe entirely painless, but you are absolutely certain it was not there yesterday.
Which is, a terrifying prospect for anyone.
Oh, for sure. You go to the doctor, and what follows is not just some simple outpatient extraction. It is the beginning of this incredibly delicate surgical process.
Because the doctor has to extract a tumor from tissue that is intimately tangled with the nerves controlling every single expression on your face.
Right, the terrain we are talking about is intensely unforgiving. The stakes are not hidden away deep inside the body, they're written right across the face.
Yeah, a fraction of a millimeter can literally mean the difference between a normal smile and permanent facial paralysis.
So today we are taking a deep dive into parotidectomies. That's the surgical removal of the parotid salivary gland.
We're going to explore both superficial and deeper sections of this gland, really unpacking the mechanics of how doctors navigate this space.
The goal today is to explore this high-stakes tightrope that head and neck surgeons walk. I mean, they have to balance the absolute biological necessity of eradicating the tumor, the delicate preservation of the head and neck.
Exactly. We will decode the physical clues surgeons look for, trace the historical evolution of surgery, and look at the frankly bizarre ways the human body rewires itself going under the knife.
Okay, let's unpack this. To really understand why this surgery is such a massive undertaking, we first have to understand the strange anatomy of the parotid gland itself.
It's the largest of your major salivary glands. It's right there on the side of your face, wrapping around the back of your head.
But the big shocking sources of discovering the parotid does not actually have the same lobes.
Right, you always hear terms like superficial lobe and deep lobe.
Yeah, but that division is completely arbitrary.
It really is. It is a brilliant example of how medical terminology sometimes reflects, surgical necessity rather than pure innate anatomy.
So it's actually just one single continuous mass of glandular tissue.
The only reason surgeons divide it into superficial and deep zones is strictly because of the facial nerve.
The one that originates in the brain and controls your ability to blink, smile,
The only reason surgeons divide it into superficial, that nerve runs straight through the middle of the parotid tissue. Roughly 70 to 80% of the gland sits above, or lateral to, this nerve.
So anything above the nerve is deemed the superficial lobe, and anything below it, or closer to the cell, is the deep lobe. I mean, operating on the parotid isn't like removing a discrete self-contained organ like anything. It is like trying to remove a block of wet concrete while carefully preserving a highly delicate fiber optic green cells running right through the middle.
I love that. And for a very long time, surgeons just did not have the tools or comprehensive anatomic mapping to protect that fiber optic cable.
The historical cost of ignorance here is incredibly high.
It was brutal. If we look back to the early pioneers, like John C. Warren at Massachusetts General Hospital in 1846, he performed the first parotid tumor resection under ether anesthesia.
But the result was serious facial disfigurement.
Yeah. Early surgeons simply carved out the mass as fast as possible. They didn't have microsurgery instruments.
And they could fully grasp that the facial nerve branches out to the gland like a sprawling spider web.
Right. If they took the tumor out, you were losing your facial function. It was packaged.
And for decades, that was just the grim reality of the procedure.
It really was. I mean, surgeons in the late 1800s and early 1900s started making anatomical strides, mapping out the space. But the real turning point didn't happen until W.E. Sisson at the Mayo Clinic in 1927.
What did he do?
Well, he firmly advocated that surgery was the only cure for a parotid tumor. But more importantly, he introduced a deliberate technique aimed at identifying and preserving the facial nerve before removing the tissue.
But even with a pioneer pushing for nerve preservation, it took a long time to become the standard.
Oh yeah, it took a massive landmark study to change the everyday standard of care. The Mayo Clinic eventually published results comparing a 15-year period from 1940 to 1954, where surgeons mostly used simple local resection.
Basically just plucking the tumor out.
Exactly. They compared that against a second 15-year period from 1955 to 1969, where they systematically identified and preserved the facial nerve while doing a formal parotidectomy.
And the data was undeniable.
Preserving the nerve while meticulously removing the surrounding glandular tissue drastically reduced both the recurrence of the tumors and the incidence of facial paralysis. It became economically controlled.
So bringing it to the modern day, before a surgeon even makes an incision, they have to act as medical experts.
Because going in blind is disastrous. That nerve runs right through the tissue.
So they have to decode the lump first.
The first piece of the puzzle is purely statistical. The good news for anyone finding that lump is that approximately 85% of parotid neoplasms or tumors are completely benign.
Okay, that's a relief. What are the most common benign ones?
The most common are called pleomorphic adenomas, which are slow-growing masses made of mixed cell types, and Warthin tumors, which are often fluid-filled cysts.
But the malignant tumors are the real nightmare scenario here. What are surgeons most worried about finding?
Statistically, the biggest threat is something called mucoepidermoid carcinoma.
Real nightmare scenario.
It is. A massive SEER database review of over 22,000 cases showed that this specific cancer is the most common salivary gland malignancy. It makes up roughly 31% of the review cases.
And it can be highly aggressive, which is why the physical examination is so critical. A surgeon's hands can tell us.
Absolutely. If the mass is mobile, meaning it slides around a bit on the skin and the breast, that is usually a strong indicator that it is benign.
And what about the Warthin tumors?
Absolutely. If a patient comes in with a long history of smoking and presents with a squishy cystic parotid mass, the detective work points heavily toward the benign Warthin tumor.
But if there is pain, or if the lump is growing rapidly, or if the patient already has existing facial paralysis when they walk into the clinic,
that is a huge red flag.
Yeah, that means the tumor has likely already started invading and destroying the patient.
Exactly. Once they evaluate those physical clues, they immediately move to imaging.
Yeah, that means
CT
the tumor has
scans and
likely
especially
already
MRIs
started
with contrast dye. Exactly. Once they evaluate those physical clues, on certain MRI scans, malignant tumors show up as dark, dense fluids. Radiologists call it low signal intensity on the T2 weighted image. On certain MRI scans, because they are packed tight with rapidly dividing dense cancer cells, rather than the normal brighter fluid you would see in healthy tissue or a benign cyst. And malignant tumors also behave differently than contrast dense cancers. They absorb the dye earlier and hold on to brighter fluid you see in healthy tissue.
Okay, I have to push back on a specific diagnostic tool used before surgery. Often, doctors will use a fine needle aspiration or an FNA biopsy to poke the tumor and sample cells. But the sources mention that an FNA has a 10% false positive rate. With a margin of error that high, why on earth would a surgeon rely on a needle probe before deciding to undertake such a risky nerve-exposing surgery?
What's fascinating here is that surgeons share that exact skepticism.
Oh, really?
They do not use the FNA as the absolute final word to plan a radical, nerve-sacrificing surgery. The FNA is incredibly useful for vulnerable patients. Imagine an 80-year-old patient with a severe heart condition. As the FNA comes back indicating a benign Warthin tumor, the doctor might decide to just observe the lump over time.
Rather than risking putting that frail patient under general anesthesia for wounds.
Exactly. The FNA provides a highly educated guess that guides overall risk management, deciding if they should operate at all. Plus, surgeons use frozen section analysis during the actual surgery. It has a lower 5% false positive rate. They use that to confirm the diagnosis before they ever decide to sacrifice analysis.
So the frozen section comes back more accurate. The patient is asleep, but the surgeon still can't actually see this microscopic nerve hidden inside the gland. How do they physically make the first cut without finding blood?
It starts with an incision designed to hide the scar. It's commonly called a modified Blair incision.
That starts near the ear, right?
Yep. The surgeon cuts starting right in front of the ear, tracing down behind the earlobe, and blending into a natural crease in the neck.
And then they peel that skin, right?
Right. They carefully peel back the skin and elevate a layer of tissue called the SMAS flap, and blending that stands for superficial musculoparotid system.
That is quite enough.
It is. But they keep this thin layer layer of muscle and fascia intact so they can fold it back later. It helps fill in the dent left by removing the parotid tissue, preserving the natural contiguity of the patient.
But once they are inside, they still don't magically see the facial nerve. They have to rely on raw, tactile landmarks.
Because soft tissue shifts and moves during surgery. A surgeon has to anchor their navigation to things that do not move, like bony cartilage.
Right, so what are they feeling for?
Well, they run their finger along the rigid cartilage of the external ear until it reaches a sharp point. This is called the cartilaginous point.
So what are they
And it literally points to the finger along the
So
rigid
wild.
cartilage.
And they also palpate the tympanomastoid suture line.
Exactly. This is a tiny physical groove in the skull where two bones meet.
So wild.
You can
And they
literally
also
feel it like
palpate
a crack
the
of tape.
tympanomastoid. They also locate the posterior belly of the digastric muscle in the upper neck, because the facial nerve always exits the skull exactly near these rigid bony muscles. They also locate
And once they find the main trunk of the nerve exiting the skull, they have to carefully follow it as it branches out from the plant.
And there are strict rules for this. Dissection must always be parallel to the main trunk.
Right, because the branches of the nerve spread out like limbs carefully follow it. If a surgeon cuts perpendicular to the trunk, they run the massive risk of snipping the branch clean off.
Oh wow. And the anesthesiologist has rules too, right?
Yes. If they're strictly forbidden from using any long-acting parallel drugs,
Because they need the face to be able to move during the surgery.
Exactly. The surgeon uses a tiny electrical probe to stimulate the tissue as they work. If they're close to the nerve,
they need the
they can
face to be
literally
able to
watch
move
the
during
patient's
surgery.
face twitch. The surgeon uses a tiny
It provides instant, real-time feedback that the nerve is alive and intact. Here's where it gets really interesting. Think of the intense irony of modern medicine. We have harmonic scalpels that use ultrasonic vibrations to cut and seal tissue simultaneously. We have high-tech MRIs utilizing immense magnetic fields, but at the absolute critical, life-altering moment of the surgery.
It comes down to a highly trained surgeon literally feeling around in the dark for a tiny bony groove in the skull to guess where a microscopic nerve is going to emerge.
Yes, it is the ultimate fusion of modern technology with classical, tactile, anatomical mastery.
It truly is. But finding the nerve when the tumor is sitting comfortably on top of it in the superficial level is one thing. The complexity multiplies exponentially when we talk about the details. What happens when the tumor is hiding beneath the nerve, which deeps against the base of the skull?
That is the dumbbell dilemma. As a deep lobe tumor grows, it has nowhere to go but outward towards the skin. So it physically pushes the entire facial nerve outward, stretching the nerve tight until the surface grows.
And before they even make an incision, doctors can sometimes spot this on an MRI. There is a blood vessel called the retromandibular vein that normally sits deep inside the bone.
And if the tumor is deep,
If the MRI shows that vein visibly displaced, laterally pushed outward toward the skin, it tells the surgeon the tumor is deep, and the delicate facial nerve is going to be stretched paper thin right over the top.
and the space inside the jaw is incredibly cramped. There is an anatomical bottleneck called the stylomandibular tunnel. It connects the deep carotid area to the parapharyngeal space.
which is essentially the side of your brain.
Right, so if a tumor grows through that tight tunnel, it gets squeezed in the middle and expands on both sides.
We're getting a literal dumbbell shape, which is part of the tumor is in your cheek, and part of it is bulging into your throat.
To safely extract a tumor that spans two entirely different anatomical zones without tearing the facial nerve draped over it, I mean, that requires extreme access. To safely
A standard neck
extract a
incision will
tumor
not
that
provide
spans two
enough
entirely
room.
different
The surgeon might have to sever the stylomandibular ligament to open the tunnel. They might have to cut the digastric muscle.
And there are specific rules even for that.
Yes. If they cut through the muscle fibers themselves, the muscle will not heal and function again. It has to be cut at the
And there are
tendon, the
specific
ligamentous
rules
portion,
even for that.
if they ever want to sew it back together successfully.
And in the most extreme, massive deep lobe tumors, they actually have to perform an endotheliectomy.
They literally saw through the jawbone to swing the mandible out of
And
the
in
way
the most
just to get
extreme,
their hands into
massive
that
deep
deep
lobe tumors,
space.
the level of structural disruption is just
They literally saw to achieve that access. They're forced to sacrifice a sensory nerve called the great auricular nerve,
The level of
which provides
structural
feeling to the earlobe in the side of the face.
But a severed nerve doesn't just stop working,
sacrifice
right?
sensory
It
nerve
tries to heal.
called the and to prevent a painful neuroma from forming, which is when a severed nerve end bundles up into a highly sensitive, painful ball of tissue. The surgeon will carefully bury the live, cut end of the nerve deep into a nearby muscle,
Essentially tricking it into stopping its chaotic growth.
Exactly.
With all this jaw sawing and muscle cutting, what happens if the deep lobe tumor is malignant? Do they just take the facial nerve out with it to be safe?
Well, we connect this to the
With all
broader
this
philosophy of
jaw sawing and
oncology. There is a
muscle
critical
cutting,
directive
what
for carotid
happens if the deep lobe
surgery.
tumor is
Even if a deep lobe tumor is confirmed to be malignant, the surgeon must try everything to preserve the facial nerve. The only exceptions are if the nerve is physically encased by the tumor mass, or if that frozen section analysis proves that cancer cells have aggressively infiltrated the nerve fibers themselves.
Because microscopic cancer cells left behind on this preserved nerve
Or
could
if
be
that
treated later
frozen
with
section
targeted
analysis
radiation.
proves that but a deliberately severed facial nerve alters a person's life forever. You cannot radiate away a severed nerve.
The functional and psychological impact of losing the ability to smile or close your eye is
alters a person's life forever. The preservation is paramount. Radiate away. But even if the surgeon executes this high wire act flawlessly,
right. Even if they remove the tumor entirely, save the nerve, and close everything up beautifully.
the sheer disruption of the parotid tissue causes the body to rewire
Even
itself
if they
in truly
remove the
bizarre
tumor
ways
entirely,
during the
save the
recovery
nerve,
process.
and close aftermath. This is where the biology gets genuine.
One
One of the most common complications is freezing, also known as gustatory sweating.
Up to 60% of patients experience this after surgery.
This is what
It is a fascinating consequence of the
One
human
of the most
process.
common
When the surgeon removes the parotid gland, they are also severing all the tiny parasympathetic nerve endings.
These are the nerves that used to send the signal to the gland to secrete saliva.
Exactly. And as the surgical area heals over the following months, those severed saliva-producing nerves start to regenerate. They are desperately looking for a target to connect to.
But the salivary gland is gone.
Right. So in their confusion, they mistakenly attach themselves to the sweat glands in the overlying skin of the cheek.
So what does this all mean? It means a few months after surgery, you sit down to eat a delicious, mouth-watering piece of lemonade.
And instead of your mouth watering, your cheek starts profusely sweating.
The signal gets completely crossed. It is exactly like a computer motherboard trying to solder itself back together after being smashed.
That's a great way to think of it.
It eventually works, it gets the power flowing, but occasionally it connects the audio wire to the printer board, leading to these bizarre cross-anatomical wires.
And that crosswire scenario doesn't just stop at sweating. Patients who undergo those extensive deep lobe or parapharyngeal dissections can develop something called first bite syndrome.
First bite syndrome.
It is incredibly severe, sharp cramping pain in the jaw region. It occurs specifically on the very first bite of the meal.
Ouch.
And then it subsides as they continue. It is another consequence of the sympathetic nervous system misfiring after profound surgical trauma.
There's also the risk of a sialacilla or a seroma, which happens in about 5% of cases.
Right, because tiny fragments of parotid tissue might be left behind, and they continue producing saliva.
But the main duct that normally carries that saliva into the mouth is gone.
So the fluid just leaks and pools under the skin, creating a swelling on the side of the face.
And how do they fix that?
The doctor literally has to go in with a needle to repeatedly drain it, or they can inject Botox into the skin. It temporarily shuts down remaining gland production. The doctor literally has to go in.
The recovery requires immense patience. I mean, the body has to find an entirely new equilibrium after major structural and neurological disruption.
It really is a profound procedure.
It is. You have this incredible contradictory blend of brutal carpentry, literally using saws on jawbones, dividing massive necklaces,
Combined with the most delicate microneurosurgery imaginable. like suturing the microscopic nerve piece into 905.
which is significantly finer than a human hair. It makes carotid surgery the quintessential head and neck operation.
It really does. And this raises an important question, one that sits at the very intersection of clinical medicine and human identity.
What's that?
Well, pleomorphic adenomas, those highly common benign carotid tumors we discussed earlier, they have a roughly 5 to 10% chance of undergoing malignant degeneration if they're left in the body long term.
Meaning a harmless lump can, over years or decades, spontaneously transform into a deadly cancer.
Exactly, because a biological ticking clock. Given that ticking clock, and considering how intricately our facial nerves define our emotional expression, our human connection, and our core identity, it forces a profound, deeply personal choice. At what point does the daily psychological anxiety of watching and waiting for a benign lump outweigh the immediate physical risk of potentially losing your smile on the operating room?
Wow, that is a complex calculus that every patient with a carotid mass has to navigate.
It sits right at the core of what it means to be human in these medical interventions.
So the next time you look in the mirror, maybe wash your face, brush your teeth, take a second to appreciate that smile. The anatomical machinery behind it is incredibly fragile. So the next time you look in the mirror, entirely irreplaceable. Wash your face. Thanks for joining us on this deep dive, and we'll catch you next time. The anatomical machinery behind it is incredibly fragile, fiercely complex, and entirely irreplaceable. Thanks for